Good morning, everybody, and welcome to this morning's webinar. This webinar is part of the European Connected Health Alliance Thematic Innovation Ecosystem on Digital Health and Wellbeing. It's quite a long title, but hopefully you'll understand what we mean as we go along. Essentially, the ecosystems are about knowledge exchange, but I'm going to leave it to my colleague Andy to explain a bit more about what the ecosystems are aiming to do and who's involved. I would just briefly like to introduce you to the webinar. This morning's topic is around innovation in stroke services, and I'm delighted to say that we have speakers from Moldova and also from Scotland. I'll introduce the individual speakers as they come up, and I would just like to finally say, if you could please add any questions or observations or reflections on your own experience in this area through the chat as we go along. We will pick up the questions. We will have time for discussion and questions. So please do use the chat. You might tell us where you work, or you might tell us something that reflect on from one of the speakers' presentations. And also, as you're probably very well aware, please keep your microphone on mute and your camera off while the presenters are speaking. So that's it from me, and I'm going to hand over to Andy Bleden, who is Director of Ecosystems and Membership at the European Connected Health Alliance. Andy?
Thank you for that, Nessa, and thank you also for the introduction. Welcome to colleagues. Just a little bit about who I am. As Nessa said, I'm Andy Bleden. The clue's in the title. I work for the European Connected Health Alliance. Many of you know us as the ECH Alliance. We're a member organisation with over 900 member organisations spread across the globe. So in practical terms, most of those are not-for-profit, hospitals, universities, public bodies, government agencies, etc., patient groups especially, and also companies. That represents about 20,000 people. Now, what we do as a not-for-profit is bring those organisations together through a series of ecosystems. We involve them in our initiatives and our projects. We do that because we, as the Global Health Connector, are here to connect up the dots in health and social care. People join us because they want to promote their organisation, they want to connect, and they want to meet other people and grow their network. We'll put some links in if you want to join us. For not-for-profits, it's free, and we'll put that in the chat function now. But that's not what today's about. Today is about our ecosystems. We see ecosystems quite clearly as bringing all those stakeholders of health together, but with an idea of matching need and solution. Nothing more complicated than that. There's no big theory behind this, but we see them as being permanent gatherings like this one on the topic of digital health and wellbeing, but looking to break down some of the silos that exist so we can exchange best practice and need. We can transform healthcare delivery. What does that mean? It actually means we actually do something together and collaborate. But lastly, there's also an opportunity to create economic growth. So we've set up a whole series of network of ecosystems, including in Scotland and Moldova, which I'm pleased to say are speaking today. But 70 ecosystems all over the globe, ranging from Argentina up to all the way across the globe to Australia and back again. What those do are collaborate. They collaborate and bring together all those stakeholders together, and across the globe have started to develop and build a series of what we call thematic ecosystems. Now, those are baked in collaborative networks. So the one today, the digital health and wellbeing one, is explored a number of different topics with the idea of matching up need and solution from different countries. That's all I'm going to say about today, because I think what I want to get on in here is about the subject matter for today, which is around stroke rehabilitation. And we've got some great examples from both Scotland and Moldova. Stroke rehabilitation is probably, for many people here, something they're either passionately involved with or been touched by within their own family circumstance. I'm no exception. So I'm going to hand back to Nessa, who's going to introduce our speakers today. Please feel free to get involved, use the chat function and ask some questions, and let's get the conversation going and let's start connecting up some dots. Nessa, over to you.
Thanks very much, Andy. And first up, we have a presentation from Dr. Alexandru Gaznas, who is Assistant Professor at the Department of Neurology at the State University of Medicine and Pharmaceutics in Moldova. And Dr. Gaznas is going to speak to us about the approach that they're taking in Moldova, an innovative approach, and looking at how they can support the treatment of stroke and management. Dr. Gaznas, I'll hand over to you.
Okay, thank you for the nice presentation. So I will focus on organization of emergency care service for stroke patients in Republic of Moldova and in implementing the telemedicine. And I'll focus some subjects and topics. The first will be the premises of a stroke system in Republic of Moldova. Moldova is a small country, but of great tradition. It's near Romania and Ukraine. And Moldova is the home of the largest underground wineries in the world. And the Melești and Cricova has more than 200 tunnels of wineries. So you are welcome to come in Moldova. But from demographical point of view, historically, we are known to be 4.5 million population. But now we can see the tendency starting from 2014 due to migration and other factors. In 2021, we are 2.5 millions. More than statistic in Moldova is that we have more than 80,000 stroke patients already, and kind of 3% of all Moldovan population has a stroke. And it's a problem because we're focused a lot on the acute treatment of stroke, but we forgot about rehabilitation of these patients. And the health system in Moldova, it's also a kind of problem because it's an unfavorable indicators of a whole European area, not only in the European Union countries, but also in the Central and Eastern European countries, because Moldova is in the top 10 in the world terms of stroke incidences. And this is the negative statistic are not only due to the low economical level of the country, but also to the healthcare system, which does not pay enough attention to the stroke patients and does not put enough emphasis on primary and secondary prevention. And also stroke is the leading cause of our disability in the adult population in Moldova. 33% of stroke patients are of working age. What we did, because we had an evolution. Till 1997, nobody wanted to be a strokeologist because all what you wanted to do is to say to the relatives, you have a stroke patient. And starting from 1997, we dedicated, my colleagues formed like a neurology department for stroke patients, not like in all general wards. In 1999, my colleagues also, we put a CT scan 20 to 24 hours for the patients with probably stroke. In 2004, we had the protocol for Doppler for all the patients with stroke, 24 hours. And it was a great thing that in 2005, we did the first thrombolysis, systemic thrombolysis to our patient. And I'll show you a video. It was like a huge step for our healthcare stroke system in our republic, making this systemic thrombolysis. Then we have a lot of and a series of projects to identify our risk factors in our population. And starting from 2007, we had different assessment, mathematical modeling and forecasting of acute stroke according to the spectrum of the risk factors in the population of Republic Moldova. Also, we studied the heterogeneity of risk factors, and with these factors, we concluded that we need something specific for this healthcare system. And in 2014, we opened the first stroke unit dedicated for the patient with stroke. And in 2018, we did the first thrombectomy in stroke patients. So again, it was a huge step for evaluation and healthcare stroke system. The idea is that comparing the data that we have in Moldova in European countries, we still lack of stroke units. And due to, we were a little bit of selfish, we concentrated everything in the capital, in Chisinau. And we forgot about the patients that are in other regions of Moldova. And now we are changing this concept. And we had really great data in thrombolysis rate and door to needle till the COVID time, because the COVID time changed everything in our system that we put, even our stroke unit, we dedicated for COVID and stroke and other patients. So we had already to change our operational institutional protocols. This is a video from 2005, the first thrombolysis we did to a patient, and these are my colleagues. I was a student then, but these are my colleagues that did the first thrombolysis. So it was like a miracle. We had a patient, we did a Doppler, a computer tomography, like a part of all the protocol that we're doing now. And we can see a hemiparesis of a patient, this palsy. We did a Doppler ultrasound of the patient, a computer tomography. The patient was eligible for thrombolysis. And we can see it was like a miracle. The patient recovered. So we thought all the patient will be saved. But in real life, it's not that. It's a time depending. And our population don't know all the risk factors and all the signs of a stroke, but everybody's afraid of stroke. And after one day, the patient was walking, she had fine motor skills regained. So this was the first patient. And after that, we saw that we need more to improve to increase the number of patients that will be thrombolyzed. In 2018, we did the first thrombectomy. So it was a huge step because we tried and to have a team of stroke unit and to have this thrombectomy to the patients. And now, starting from 2018, we implemented that. And also we have several centers that are capable of doing, we identify the teams. So how innovation and collaboration is transforming the stroke care system? Because we need a lot of studies and projects to achieve what we have now. And this is one of the biggest our study. It was an international stroke study and risk factors project. It was with our colleagues from Austria, with Professor Trinka, and from Germany in Mainz with Professor Wolfgang Aulitzky. And we studied the risk factors in different regions of our country, not only in capital, so in the north part, in the south part, east-west part. And we included that we wanted to see what are the proper risk and specific risk factors for our population and why we have such a great incidence of stroke. And also it was a collaboration of international organizations like ISOIS, European Stroke Organization, and also World Stroke Organization, angels that helps us a lot. And we also implemented the Stroke Action Plan for Europe in our country. In 2016, we had the rescue registry collection of data because we wanted to show to our government and policy making what we have real thing in our country. It's not only on papers. And in 2019, we had the first Iron Coast meeting where we implemented the first pilot study project for priority sectors for policies against stroke in Moldova. Participated more than 27 countries in this project. So in 2019, we had already a pilot project, but there was some hard time from political point of view. We changed 2 presidents, 3 prime ministers, 3 minister of health, and each time we should tell everyone what we have and what we should change. So stroke management quality registries, also we have more than 15 centers around our republic, and we are collecting the data, real data of patients of stroke to know what is happening now. And due to that, we tried to change our concept of stroke making decision and policies. Here's the first center that we changed the concept is the Institute of Emergency Medicine. It's a comprehensive stroke center. So now I'm showing that we build even a new facility here with the Department of Emergency Medicine, where it will be a room dedicated only for stroke. There will be a computer tomography near that room, will be a hybrid room for surgery and angio lab. Not to waste time. So everything will be around the patient and not to lose proper the time going in different parts of the building. So we have 5 departments, 2 neurosurgery departments, we have stroke unit, we have the angio lab, 1 MRI, 2 computer tomography, 1 dedicated for neuro patients. And we have two scientific laboratories for primary and secondary risk factors and for cardiovascular, and one cardiovascular laboratory to study the risk factors and to manage them. So the national project, what we wanted to accomplish is, first of all, for precision of diagnosis, high quality stroke care, neuroimaging, pharmaceutical treatment of systemic thrombolysis, minimal invasive treatment, and minimizing unnecessary transport for mimic of strokes, and improving the patient's quality of life and life expectancy. So here we can see the regionalization of the stroke centers, because everything was concentrated here in the capital, in the center. Now our authorities are building two new regional hospitals in the north part and in the south part. And we have a comprehensive stroke center, and we have two capable of thrombectomy centers in Chisinau, and 7 primary stroke centers we try to connect with comprehensive stroke care center. So the idea of stage triage process, so identifying the symptoms, we're using joint triage. So patients call 112, and they were making the triage to decide to go in the primary stroke center or in comprehensive stroke centers, or to bypass that and go directly to the comprehensive stroke center. And also pre-notification via telestroke application, because nobody till now knew when a new patient will arrive. So also it's a problem for our pre-medical emergency system to know where to go with the patient, not just to bring the patient. And all these stroke patient triage of stroke centers are very important. So understanding the joint triage is for emergency transport triage, for connected medical institution, for hospital mode, and also to reduce transport time, to reduce door to treatment times, and also decision making, what to do with the patient. And also we have hospitals in a different region of our country that don't have specialists for neuroimaging. They have technician, and all the information will be sent 24 hours, and will make these consultations through telemedicine. So how can we build a brighter future for stroke patients? First of all, it's important to know why people die, and then to improve how people live. So we have a lot of statistics, and doesn't matter it's a low middle income or it is a high income countries, stroke everywhere is a problem. And we also know that starting from 90s, we have changed the paradigms of stroke treatment, and beginning with thrombolysis era in 90s, and also thrombectomy, and we know how patient benefits from that, but we need also to have a good healthcare system to deliver these types of treatment to the patient. First of all is the prevention, but knowing all the risk factors, 80% of strokes could be prevented through lifestyle changes, but also we have a lack of in different other types of problems like atrial fibrillation, and we need to increase the proper prevention of different types of risk factors, hypertension, metabolic syndrome, and atrial fibrillation. And also we have heterogeneity of a stroke pathophysiology. So the well-known dictum of time is brain has been revised. So it's not only about losing connections of the brain. So we have fast progressor, slow progressor of infarct growth, and we know the range of neurons lost per minute, it's more than 27 millions. So it's a problem. And mostly 55% of patients with large vessel occlusion strokes are slowly progressive, and it could be misleading, have a low NHS score. The patient could have another type of treatment, but not thrombectomy, and it's not a life-saving, and it's also a problem. Also ensuring universal access to optimal treatment. So the big challenge is equity. So we will require a reorganize of a stroke infrastructure, also comprehensive stroke centers, primary and secondary stroke centers, and always the winner will be with the patients with severe stroke. Also, improved understanding will lead to better outcomes. And rural communities and those with under-equipped health facilities are typically most in need of improvement. And telemedicine improves that, and they haste the diagnosis, reduces the costing, and improving the outcomes. And we know all the telestroke programs, we have a lot of researchers on that, and it's shown to cut the stroke to needle time in half. So telestroke units can provide sustainable, high quality treatment in rural areas. So my conclusion would be that we need to build a national stroke plan for the beginning, yes, and also capable of offering the best possible treatment to all patients eligible for a perfusion therapy. So it's a must. We need to build a national stroke program, but we should know all the risk factors. We should know our problems, when to address and to this problem by building this stroke plan. And also we need to organize all the elements to have a good cooperation of pre-hospital assessment, strong commitment of all stroke physicians, and also we need registry and to see what is the real data in our country, in other countries also, and also to go to the government that are involved to establish stroke care as a priority and to show them how we need to change all the system to have a good quality and a good stroke care system. Thank you.
Thank you. Thank you very much, Dr. Gaznaz. That was really interesting overview of the service, but also picking up some points there. I'm sure will come up in the discussion about the importance of education, not just for the citizens, I would say, but also for the health practitioners as well. I'm just going to hand over directly to Professor Dennis, to Martin, and let you do your presentation, and we'll pick up the questions after our speakers. So, Professor Dennis, over to you.
Thank you very much. I hope that you're now seeing my first slide.
Yep,
I'm going to talk
perfect.
about stroke services in Scotland. As you'll see in the map on the right-hand side, Scotland is geographically quite a large country. It has a population of 5 million. It has about four large cities, Glasgow, Edinburgh, Dundee and Aberdeen, but also large areas which are quite rural and remote. And this poses challenges for delivering stroke services. Scotland is divided into 14 NHS boards, National Health Service, free at the point of receiving healthcare, and it's divided into 14 regions, varying in population from 30,000 up to about 1 million in Glasgow. We've had a national strategy for stroke since 2002, when the Scottish Government made stroke a priority. Every health board was expected to establish a managed clinical network, an MCN, which linked health and social care staff and involved the care of patients along the whole pathway, from prevention through to secondary prevention and long-term support in the community. Each managed clinical network had a lead clinician and a manager. Every MCN participated since then in the Scottish Stroke Care Audit, which is a registry of all hospitalised patients with stroke, which has run since then. We register around 10,000 inpatients a year and 3,000 or 4,000 outpatients a year. And you can see a link there to our annual reports. Each MCN ran patient and public involvement groups, and it emphasised the importance of staff training to improve the delivery of stroke care. And we developed several national programmes of online training, which I think you've been provided links to. And those are free for anybody to use, and they can provide certification for individuals who are participating in stroke care. The most recent of about 5 revised national plans for stroke was published in 2019. It was under the so-called Programme for Government. It was aiming to introduce a Scotland-wide thrombectomy service. We were lagging behind this for a number of reasons, and we have tried to bring about a 24/7 thrombectomy service based on 3 thrombectomy centres. We were also, as part of this plan, asked to scope out what we described as a progressive stroke service. We published that document just in the last 2 or 3 weeks, and there is a link to it. This was informed by horizon scanning run by our National Planning Board, evidence-based guidelines, both UK and worldwide guidelines, broad involvement of stroke specialists in medicine, nursing, the allied health professionals, physiotherapists, occupational therapists, psychologists, third sector organisations such as our charities involved in stroke care, and also our National Patient Voices Group, who are a group of patients and carers with lived experience of stroke who looked at our plans, commented, and they were adjusted to take their views into account. This progressive stroke plan aimed to cover the whole pathway from primary prevention, particularly focusing on those bits which are stroke specific, thinking about the better management of blood pressure and atrial fibrillation in both primary and secondary prevention. Looking at the acute part of the pathway, the recognition, transfer to hospital, hyperacute treatments, which my colleague in Moldova has already described. Also covering the management of minor strokes and TIAs, the delivery of thrombolysis and thrombectomy, but also ensuring that stroke unit care is as good as it can be. All of our 25 stroke-ready hospitals have had stroke units for the last 20 years. However, they vary in quality and their ability to deliver high-quality stroke care. This we're always trying to improve, and we're monitoring by our Scottish Stroke Care Audit. We're now paying attention more to those 20% of patients with hemorrhagic stroke, where we believe we can improve outcomes. And our pathway also deals not just with stroke unit care, which would cover inpatient rehabilitation, but rehabilitation into the community through early supported discharge services, long-term prevention, life after stroke clinics, supported self-management. There are challenges. We have an increasing number of patients with stroke because of our aging population. And in Scotland, we have a higher rate of stroke per unit population than other parts of the UK and in many other countries. We have constraints on NHS funding, post-Brexit, post-COVID, and now it's being impacted by the European war. We have lack of numbers of healthcare and social care staff. We have problems with the NHS not necessarily prioritising those things which have greatest impact on patient outcomes. Often it's based on other factors, historical factors. We see variable ability of stroke services to improve and change. Some of our managed clinical networks are not sufficiently influential in their area to bring about the change which is necessary. And as I suspect in any systems, we have silos. We have different departments which don't talk to each other. And this occurs in the Scottish Government, the NHS in Scotland, and even in each NHS board, where there's disconnection and therefore suboptimal planning and delivery. And in particular, when we're thinking about digital health, we have poor IT and e-health investment in the health service compared with, for instance, commercial organizations. And this leads to poor or very variable infrastructure. I'm going to spend the rest of my talk talking about some of the digital solutions that we use or are dreaming of using in the future. For a number of years, we've had the advantage of having a national picture archiving system, which allows us to share brain imaging across the country. Wherever we can see brain images carried out in any of our 25 hospitals. We have had telestroke with video conferencing facilities between all of our stroke-ready hospitals and other hospitals to allow urgent decision-making. And we're increasingly using that to deliver other aspects of stroke care, such as TIA care and rehabilitation. Building on this now, we are trying to implement what are referred to as AI or artificial intelligence systems, such as those developed by Brenomics, Rapid AI, Viz AI, and Nicolab Stroke Viewer, which allows us to rapidly distribute brain images to people's mobile phones, and also a very rapid interpretation within 2 minutes of any CT scan, CT angiogram, CT perfusion, which can guide the use of both thrombolysis and thrombectomy. We're aiming to have one system in place within the next year or two, although currently we have 3 or 4 systems being trialled by different centres. The Scottish Government has bought Microsoft Teams to support communication between all healthcare and social care workers and government. We are now working with Microsoft Teams to support communication along the hyperacute pathway in stroke. We can embed applications within Teams. We're looking at the improvements in both primary and secondary prevention of stroke and self-monitoring systems by which patients check their blood pressure or their heart rhythm and report that via text to a central system, and then receive information about how to adjust their therapy are being rolled out across Scotland. And there are 3 more innovative systems, one called Tailored Talks, to share tailored information for patients to better involve them in shared decision-making and self-management. A stroke assessment app, which is being evaluated in Glasgow to allow healthcare professionals to rapidly record the history, the examination, the assessments, and the treatment of patients on their mobile phones. And other systems, which aren't stroke specific, which aim to help us plan, prompt, deliver, record, monitor, and improve the delivery of care. I'm going to talk a little bit more about each of these. First of all, Tailored Talks has been developed over the last 5 years. It's a web-based system. It allows us to tailor information for individual patients and their families, no longer relying on leaflets or websites where patients have to identify what information is relevant to them. This information is tailored by a healthcare professional. Images and multimedia can be included to improve their understanding. The information can be structured in a way that prompts questions and discussion between the patients and their doctors and nurses. It creates one consistent communication pathway. The talks can signpost individuals to other online resources and other local services. It captures feedback from patients and families. One can share the information both on paper, if they don't have access to IT equipment, but also on screen during face-to-face consultations, or remotely by email or SMS or WhatsApp. And we can share the information synchronously or asynchronously. It provides information such as this, which we might use to counsel a patient about the pros and cons of going on to anticoagulation with atrial fibrillation, providing information both in words and numbers, but also pictograms to help them understand the possible benefits and risks of treatments, really involving the patients in which decisions which treatments they get. There are planned developments to take tailored talks further, broadening access to all healthcare professionals involved in stroke pathways across Scotland, broadening the content to cover all aspects of stroke, including rehabilitation. Being digital information, we can introduce speak out loud function for those with poor vision, and in the future, non-English language versions for those who do not have English as their first language. And at the moment, a patient application, which can be used on their own mobile phones, is aiming to support their self-management in various long-term conditions, long COVID included, but also stroke. In Glasgow, they have been developing a stroke assessment application. This allows clinicians to record the history, examination, assessments, progress, and treatment on their mobile phone. This information can be shared amongst the healthcare team along the pathway in real time. It inserts the information into the patient's electronic health record when they're in hospital. And it populates the fields in the National Stroke Audit without needing to duplicate data entry. This is just one screen of data entry taken from that system with the ability to add a patient, their unique identifying number and their date of birth and surname, and then information about their background, their stroke, their assessments, and the recommendations for treatment. The aspirations of modern healthcare are that our care should be patient-centered, safe, effective, efficient, and we deliver the right care at the right time every time. We recognize from 20 years of national audit that we fall well short of these aspirations. In particular, many things we hope to deliver, we fail to deliver at the right time, with every time. We're introducing a system called Care Calendar, which aims to plan, prompt, deliver, and improve care. This indicates that the multidisciplinary team looking after patients with stroke or any other condition can put together a plan within a calendar for the patient. The healthcare workers working with that patient can then be prompted to deliver any assessments or interventions at the right time. They can record delivery of that care so that then one gets real-time information about the delivery of care, not via an audit 3 months, auditing information 3 months old, but in real time. This allows any omissions of care to be identified immediately when they can still be managed, but also allows managers to rapidly improve care through PDSA quality improvement cycles. Like existing systems, Care Calendar, which is being developed, works like Patient Track or Vital Pack, which are other digital systems which have been rolled out in England and Scotland, that they can also prompt things like the news observation system and record assessments and interventions. However, unlike existing systems, Care Calendar aims to be more intuitive by looking and feeling like a digital camera where you can add events and to-do lists. It allows clinical teams themselves to configure the system to meet their requirements and not rely on the vendor of the system or IT staff. It prompts any event to the team or the patient, which is considered important and can be used by any healthcare team in hospital or in the community or in the interface between them. It is not a stroke system. We don't think that stroke systems will be popular with our NHS managers. They want more generic solutions which can be tailored to conditions. Uniquely, the Care Calendar also offers the patient the view of the care plan and allows them to influence its delivery and planning. This is an example from the demo system we've developed, which shows you a calendar for an individual patient in an individual ward and shows you those upcoming events which need to be carried out for the patient in purple, events which have just recently been completed in grey, and things which haven't been done, which should have been done in red. So a ward manager can immediately see how things are going. And there's a mobile app view for the individual healthcare worker working at the bedside to see what work they need to be doing in the next few minutes and hours, and they can record what they're doing with the patient on this system. The potential benefits of healthcare staff are that they get reminders to deliver important aspects of patient care. They worry less about forgetting to do things for patients. They're less reliant on the flawed handover procedures between shifts. They have more streamlined recording of the care they provide, and therefore more time to give to the patients. And this is important given our lack of staffing. They can be more confident that their patients will receive the planned care. They'll receive fewer complaints about omissions of care and poor outcomes. They can intervene, they can insert an event at any time for any event which has to be reliably delivered, and hopefully achieve better outcomes for patients and better satisfaction for patients. The same are that there are hopefully going to be benefits for both patients and their families, including better outcomes and reduced length of hospital stay. I'll finish there and I'll happy to take any questions a little later. Thank you.
Thank you. Thank you very much, Professor Dennis. That's really, really interesting. And again, like Dr. Gazna's presentation, just emphasizing the impact of stroke across the system, across the services, and most importantly, for the people involved and their families. It's a really widespread impact. I'm going to hand over, and thank you. I see people put questions in the chat, and please do keep doing that. And I'm just going to hand over to Professor Lorna Paul, who is our final speaker, and then we will pick up the discussion. Professor Paul has the hard job, a little less time than the others to speak, but she's going to speak to us more about rehabilitation and a specific example and development that she's directly involved in called Giraffe, but I will let you explain all. Professor Paul.
Thank you very much, Nessa. Can you hear me all right?
Yep, we can hear you.
Yeah, and you can see the slides.
Really well.
That's perfect. Thank you. Lovely. So my name's Lorna Paul. I am founder of Giraffe Healthcare. I also work part-time, well, full-time really, as an academic at Glasgow Caledonian University. So Giraffe Healthcare is a not-for-profit, a social enterprise company, which we set up because we realised that there wasn't a good platform for remote delivery of rehabilitation services. We started with specifically physiotherapy, but over time we have users who are physiotherapists, occupational therapists, podiatrists, and some nurses as well. So what is Giraffe Healthcare? What is the platform? Well, the idea really is patients were, this was pre-COVID, not all patients were able to access rehabilitation. And even if they were able to access rehabilitation, it often wasn't for long enough, and they weren't feeling very supported in that process. So the platform allows the therapist to set up an exercise program, a rehabilitation program for the patient, which is personalized to their needs. It's interactive. The therapist and the patient can interact through the chat function, and because the therapist can remotely see the exercise diaries that the patients are completing. So the therapist can respond and progress the patient's program appropriately without them always having to come into the clinic to be assessed and their program updated. So it progresses with the patient as the patient progresses through their journey. So it's not stroke specific, although I'm going to talk to you today about how the platform is being used in some stroke services. So we've talked a lot this morning about the acute phase of stroke, and obviously that's really important in terms of survival. But for us, from a rehabilitation point of view, what we know is that for people who recover from stroke, who survive their stroke and have residual problems, rehabilitation is very important. And we also know that the more rehabilitation that people do, the better and faster their outcomes. And that's for about the first 6 months. So it's really important for us to get a lot of rehabilitation to patients, for them to do lots of practice, lots of repetitions, for the nervous system, the neuroplasticity of the nervous system to adapt to the stroke and to allow better and faster recovery for patients. In terms of clinical guidelines, I'm sure in your own countries you have your own guidelines, but the UK guideline is that from the acute stage of stroke, patients should have at least 45 minutes a day from each relevant stroke rehabilitation therapist. So that might be 45 minutes of physiotherapy, 45 minutes of occupational therapy, and so on. And that is really important. And as people go through their journey, that should then be tailored to the person's needs. Now, wherever you work, you'll probably realise that 45 minutes is almost impossible to deliver. It's certainly impossible in our current NHS in Scotland because of staff shortages, because of high number of patients, because of the regulations around the treatments with social distancing and so on, because of COVID. So we need some way to make sure we can deliver these clinical guidelines to patients. And that's really where the Giraffe platform comes in. And we've heard we're all about improving clinical outcomes. We want to be able to deliver therapy in line with these international guidelines. What the platform can be used is to deliver a 7-day service. So even if the patient gets a bit of therapy time, it's usually Monday to Friday. There's nothing happens in the evenings, there's nothing happens at the weekends. So we can set up the patient's programme to allow them to do some more therapy either in the evenings or weekends, perhaps with family and friends. Also, as the patient goes through their journey, perhaps moving from acute stroke wards to rehabilitation to community care, we can transfer the patient on the platform between the therapists. So each therapist is not starting from scratch to assess the patient. The patient has a programme that they can continue. We've talked about communication already. We want to improve the communication, and we have aphasia advice pages that we can deploy on the platform. And ultimately, we're trying to empower the patients to self-manage their condition. Some things just to point out is that it's very much a video-based system, and we try and use patients as the actors in the videos. So you'll see some examples. You know, if you look at exercise videos, it's a young person who's very slim and obviously goes to the gym all the time, and of course our patients don't look like that. We're also able to have the platform and the exercises in different languages, which might be of interest. We have different ethnicities on the platform. We have different ages and stages so that it represents the communities that we're working in. As well as the exercises, partly because of COVID and the remote working that we've been doing, our users asked for new patient education videos, as well as the exercises. We have videos on things like falls prevention, using walking aids, how to use inhalers and things like that, which also might be relevant. So specifically in terms of a stroke patient's journey, how is the platform being used? Well, it's being used in some acute stroke units, as I've already said. Personalised programmes being set up, not to replace necessarily, but to augment the therapy that's currently happening, so that if somebody, say, gets 30 minutes of therapy a day, they can do extra therapy evenings and weekends, and on, as I say, taking us from a 5-day to a 7-day service. If that patient's then transferred to the rehabilitation facility, the programme goes with them, the same sort of service efficiencies, and we've got some very early data that actually using the Giraffe platform, allowing the patients to do more therapy, increasing the dose of therapy, might reduce the length of stay in hospital for some patients. Then often in the UK, patients get moved into the community teams, and one of the problems that we have across Scotland is that there's often a big gap between a patient being discharged and community teams starting to pick up those patients. platform is that the patient has their exercise program, the rehabilitation program that they can continue working on until the community team pick up the patient. Often these patients, as we talked about, can be living remotely. It's difficult to get service to remote parts of Scotland, I think, as we've heard earlier on today. So what we are seeing with the Giraffe platform is that the therapists don't have to always go and visit the patient. They can use the exercise diaries, the remote supervision of patients through the platform. So reduced appointments to patients, and ultimately, as we've all been talking about, the bottom line is we're trying to improve clinical outcomes for patients. So that's just an example of a patient journey and how the platform is being used. On the final slide here, I've put a link to our demonstration page. It's actually for an MS patient, but you'll get the idea in terms of stroke. So I'll put that in the chat as well so that you can pick that up, and my contact details if anyone's interested. Thank you very much.
Thank you very much, Professor Paul, Lorna. And if I could just ask the presenters if they're happy to put their cameras back on. I'll just remind the attendees that the session is being recorded. If you do not wish to appear on camera, don't put your camera on. I'd rather not appear on camera, but there we go. I'm here. So we're going to go over to questions from the chat. We've had quite a few, which is great, and some observations. Thank you very much. But first, I just did to ask Andy. Andy, if you had any quick reflections before we open it up.
I think there's some fascinating practice going on here. And I think, you know, I had a question firstly, and it's the same question for all panelists to think about. We've heard what you're doing. What do you need? What would, you know, what could the next step be? What could really help you? So have a think about that. What, for all the speakers today, what do you need? And then secondly, where can we connect some dots here? Because there's good practice going on here, excellence in the Giraffe project, excellence across Scotland, excellence in Moldova. How can we start connecting up some dots? I'm interested if anyone have got any, I mean, Giraffe, I'll just say, sorry,
yeah.
Just before, Giraffe, I'd love you to join us. It's free for you to join us. You're a not-for-profit, so join us as a member. Please, Dr. Gaznas, please.
Regarding the solution, I think we have a problem because we have different type of digitalized like platforms, but we need something that unifies different platforms. Because, for example, we have different hospitals that have some small part digitalized systems, but we're not connected in one big platform. And also, I think we'd like to have different viable digital solution. Because again, it's a problem because we have some projects for 1 year, 2 years, and that's all. So we need a continuity of all these platforms. Okay. And also maybe peer-to-peer learning, because to go and to see other systems, others to come here to see, so to have like this connection of peer-to-peer learning. And also to create different, to give a solution, like, and we are open for different projects and collaboration to make this viable.
Okay, that's helpful. Note that to the other people who are here today. Not just one, but several good ideas there in terms of what's needed. Any other input from other colleagues? Certainly from Scotland.
Yeah, so Martin here. I would also agree that we have the same problems in Scotland as in Moldova. I think a central registry of systems which exist. I hadn't come across Giraffe, I should have done, but how do we find out about these systems to ensure that we're not reinventing wheels, but also to ensure that we can identify possible solutions for our problems. In Scotland, despite being a very small country, we are not very good at doing things once for Scotland. We have 14 health boards who all have responsibility for their own information governance, which they all have responsibility for their own e-health. And that makes it very cumbersome, very difficult to get the same systems implemented across health boards. and very slow. We need it much better joined up, even across our very small country.
There's a reason why we've got Scotland and Moldova on this call, because very often we find small countries collaborate much quicker than great big monolithic countries. So there's other reasons. It's no accident we've got we've picked this. I think there's some great areas to think where we can scale up from one country to another. Very often we find with our ecosystem network, it takes another country adopting a local solution for the local other providers to think, oh, that looks really good, we'll have some of this. But when you see it actually deployed only abroad, and we've seen that not actually with Scotland, with an Australian solution deployed in Scotland successfully, and the Australian Health Department took interest in the Scottish deployment, didn't realise it was an Australian solution. So there's lots of examples of wheels being reinvented all over the globe. That's what we've set up the ECH Alliance for. So that's your input. I'm interested now to hear from Giraffe. What do you need, Lorna?
Well, we're a not-for-profit company, and our ultimate aim is to get rehabilitation to people that need it. So we really are open to working with anybody who feels that there is a need around their services, and that Giraffe could plug that need. We're developing the platform all the time with additional content and additional functionality. We have the same problem that Martin raised. You know, we've got contracts in some health boards in Scotland, but it is tortuous to go through all the governance in each health board. But we're plugging away at that. But that's a local issue. But we're very happy. We have collaborations in New Zealand, in Ghana, in various parts of the world. So it's the great thing about digital solutions is they're not local solutions. And we don't need to reinvent the wheel. So we'd be delighted to speak to anybody who feels that Giraffe might have a role in their service.
Well, I think you'll see in the Q&As below, there's a interest certainly from Ireland, from Aisling, I think, in one of the areas there. So you have a look at that and make a connection there. I'm going to hand back to Nessa because I'm conscious there's more questions and I haven't got a view of I can't see the questions because I'm looking at the screen. Okay. Nessa?
I'm going to jump straight in. This is a question for Dr. Gazna. So from Olga. Olga, I hope I get the sense of your question correct. I know Olga doesn't have a mic. So after a long period of mortality stagnation since the mid-1960s, Moldova has faced some progress since 2005 in females and 2010 in males. The main contribution to this improvement was decline in mortality from cerebrovascular diseases, more so in males than in females. I'm reading out the question because not everyone can see the question, so bear with me. This progress was counterbalanced by continuing deterioration in mortality from heart disease. Do you have any comments from this observation? So Dr. Gaznas, that's specifically for you.
I hope also I understood the question. I'm from '84, so I don't know really the history from '60s and other statistics, but what we can come to conclusion to what we have nowadays the data is that for sure we have more common stroke in men than in women, but usually the difference tend to decrease with age. And it's kind of a difference of, for example, it's about 4.5 years later than men in women. But I know one thing in our projects that we did, that usually the patients that, not patients, but subjects that come from young age, for example, from pediatrics to, from neuropediatrics to neurologists, they already 30% come with metabolic syndrome. So there's a problem also for screening of children's and younger age in our population. And I think that's something that we should address, and the risk factors are generally the same in women and men. Yeah, thank you.
Thank you. Thank you very much. I will just go on because we do have several questions, and obviously you can add more to the chat if you wish to do so. So I've just shared some links from the presentations in the chat as well. So we have a question from Diane Whitehouse. Are both countries expecting the situations that they face vis-a-vis stroke incidents to have worsened given the 2021-2022 COVID conditions? What will need to be done urgently in both countries and over time, the next 2 to 5 years, for example? So has COVID basically increased the incidence and made conditions worse regarding stroke specifically? If I go to Professor Dennis.
I think we have obviously seen a hit on stroke services from COVID. Not so much on the acute side, but certainly on the delivery of rehabilitation, stroke unit care and care in the community. So I'm not sure about its impact on the incidence of stroke, although we know that severe COVID can induce a stroke in a small proportion of people. I suspect we won't see a measurable impact on that, but we may well see a deterioration in the outcomes for patients due to the COVID pandemic and the impacts it has had on our health service, and we need to recover. Recovery of our health boards has varied considerably. Some are doing much better than others. Closing a stroke unit to make it into a COVID ward has very long-term implications. One loses the staff and it can take years to get back up to speed. That's a disaster, but it has happened in some health boards.
Thank you. And Dr. Gaznas, Alexandra?
So the idea is the same. I don't think the incidence increased, but it was a huge impact on the system overall of stroke care. And the idea is that the consequences are really high, because from personalized medicine, we went to the general like medicine. Everything was COVID in that time. And we reorganized all the operational protocols in the hospital, and it was a huge impact. We decreased the thrombolysis rate, thrombectomy rate, and we have a lot of patients that need rehabilitation after that. And now we are collecting all the consequences.
Thank you. Lorna, from your perspective, have you seen an impact there, more so in the community with allied health?
Yeah, I think it's the same that's been mentioned. I think it's just been a challenge to keep services going during COVID, and obviously we've had lots of staff, physiotherapists and other allied health staff who have been redeployed into COVID wards, into vaccination programs, and been off sick themselves. So staffing has been an issue through various waves, even through this current wave. The staff absence at the moment is absolutely phenomenal as we go through a big wave in Scotland here. So that obviously I can't comment on the actual instance in stroke, but certainly there's been a big impact on stroke rehabilitation services that hasn't gone away yet. But I think we're hopefully coming out the other side.
Okay, thank you. Thank you all. I also had a question, a bit cheeky. I don't know if I'm allowed to ask questions, but I always want to. And I'll preface this actually by saying that if Dr. Gaznas, Alexandra or Martin, I'm just going to go with your first names now. We all know each other. If Alexandra, Martin or Lorna, if you have a question for each other, I'll give you a moment to think about it. But my question was also related to COVID, because Andy and I have been doing these webinars for a year, and we have been participating, Andy much more so than I have, and Adriana, in a whole host of ecosystem topics and webinars, integrated care, workforce skills, capacity, all kinds of things, mental health, etc., etc. And we inevitably have talked a lot about COVID. And one of the things we've found interesting is that in some areas, some examples in integrated care, for example, the response to COVID in the countries or regions where we've been talking about it has actually driven collaboration. It's pushed people to collaborate more or more quickly, or help them to kind of get over a barrier. In other areas, and obviously the example just given for stroke services and response, because services have either paused or stopped, it's made things a whole lot more complicated. I just wondered if there were any, so I'm amending my question slightly, if there were any positive outcomes. You know, have you seen collaboration that wasn't possible before COVID? Martin, I'll go to you first.
I was going to say every cloud has a silver lining. And the implementation of Teams and Zoom has enabled us to, for instance, have a weekly session amongst all the stroke physicians in Scotland to learn about what's happening and to collaborate. It's allowed us to plan services much more quickly in an interactive way, collaboratively way. And it has overcome some of the blocks to introducing new technology. So COVID allowed us to introduce video conferencing like this very, very rapidly, which would never have happened before. So I think it is an opportunity to improve, to increase the use of digital health solutions in particular.
Thank you. Alexandra?
Yes, sure thing. It also had this positive effect on digitalization, because the population now uses the phone not only to make a call, yes, but to, and also that's like a background to implement other platforms, digitalized platforms, and to communicate with our population. And also a lot of Zoom meetings, Google meetings, and everything is digitalized. And also it will be a price to pay for that. But we need to connect, and now we have a lot of open platforms, a lot of information that we can get free due to post-COVID times and digitalization.
Thank you. And Lorna, I don't know if you want to add anything.
I don't think I've got anything to add. It's, I suppose the same. I think it's changed staff attitudes to digital health, which were pre-COVID were often very negative, you know, and you were really, well, all the people I'm sure in this room know the challenges of trying to implement digital health pre-COVID. So we haven't got rid of all those barriers, but I think people are definitely more open to digital health. And of course we have to be, because for a while that was our only mode of delivery. So it's as we come out of that, it's keeping the best parts of digital and bringing in the best parts of face-to-face, isn't it? And getting the right hybrid systems to deliver that personalised healthcare.
Definitely. Okay. Back to the questions, some quick fire questions, perhaps. This is also from Diane. Professor Dennis mentions care. Does care involve mainly hospital settings from your description, or post-discharge care, for example, general practice, or in the community, including rehab? So Martin, when you speak about care, are you including all elements, or is it hospital primarily?
Before we get Martin, just before that, what we're going to do after that, if possible, Nessa, there's a couple of questions for people who want to come in. So I think there's so many things. I think my colleague Adriana will also then grant them access to the microphone, because there's a technical list here where we need to pass the microphone over to, I think it's Olga. I've not got my glasses on, sorry if it's not Olga, but there's Olga and another person in the chat function. So we'll do Martin, and then we'll go to a couple of other people. I think there's some questions.
Thanks, Andy.
With respect to care calendar, which is in development, it isn't yet available. The ambition is that it would potentially follow the patient through hospital stay, into the community, and then back into any future hospital stay. It's really a calendar which is for them, which covers all aspects of what they need in terms of healthcare, what they do for their health and what healthcare professionals do for it. So there's no reason why it couldn't be lifelong in the future. But obviously that requires to overcome many of the barriers that we've talked about.
Thank you. So I think we have somebody coming in, Andy.
Yeah, we're just pressing some buttons now. Olga, I think we've got you being granted access to speak.
Yes, thank you.
Olga.
Yes, I'm sorry I cannot connect my camera, but I think you hear me. Yes, you hear me. Okay, yes, indeed. So why I said since the mid-60s, because it's better when you look at the situation in the health of the population for a long period of time. Then you can contrast the recent trends to the long-term trends. And indeed, in Moldova, like in many other former Soviet Union countries, we had very unfavorable mortality trends. Yes, and now the gap in life expectancy is huge between Moldova and Western countries. For example, with France, it's about, it's more than 10 years. And, but the good thing is that since 2005 for females and since 2010 for males, we had some improvements in cerebrovascular mortality. Yes, indeed, this is the main contributor, and I can connect it to the health programs, yes, to the health policies implemented in the country. But as usual, at first, females are pioneers and then males, yes, because the progress is much more evident in females. But in males, there are some improvements, but they are completely counterbalanced by a continuing increase in mortality from heart diseases. And that is why heart diseases, in fact, should be a priority for health policy makers. And another observation that these improvements, we can see, they are not geographically uniform. Yes, all the progress we can see was made in the capital of the country, in the Chisinau, and also in some northern districts. But in the central districts, in some southern districts, in fact, over the 30 years of independence, there was no progress. And I think it's very important to overcome this problem of health inequality, even for such a small country like Moldova, because we cannot achieve a sustainable, a sustained increase in life expectancy, yes, at the national level without overcoming these geographical health inequalities. Okay, it was more.
Thank you, Olga. Thank you for the context and really helpful. Just before, I'll ask Alexandra if you want to make any other comment, but I would also say, Olga, in Scotland and specifically in Glasgow, we have a mortality rate. The difference between one part of Glasgow and another part of Glasgow City is 10 years minimum, and we made significant improvements, and actually in the last few years it's been going backwards again. So we are no strangers to the difference in mortality rate and health inequalities. But Alexandra, if you wanted to comment.
No, I think it's more than clear, yeah, on that subject.
Thank you. Andy, sorry, did you?
No, just to back up what you said, Nessa, I think we've seen mortality rates get worse because of what we've done, maybe, or despite what we've done in many countries. And that worries me because I've seen it from, and the examples in England where from one side of the street to another, there's 12 years difference in age or life expectancy, 12 years. And they can see each other across the street. And there's a difference of that, which is just crazy. So interesting input. Thank you for that, Olga. If you could, Olga, if you put your details in the chat function so people know where you're from, that'd be really helpful. I think we've got Alina coming in. I'm conscious of time, but let's get someone else in. I'm going to shut up now.
Alina, over to you.
Hello, thank you a lot. So I can present myself. So I'm a nurse in the past, and now I'm actually a student at the university. And sorry, I'm a little bit nervous. About 1 year ago, I had the situation with my grandma. She had a stroke, ischemical stroke. And before that, I was nothing know about stroke and all the specifical with this disease. And what I've noticed when my grandma had this problem. So in our country, I think that it will be amazing if we can handle and make like one hospital with specific for only for stroke, because not in every hospitals we can get the rightest treatment for a person with a stroke. And because of also of COVID restrictions, I've noticed some of bad effects and also an attitude, and I'm really impressed. I'm really lucky to hear all this amazing information, and also wanna tell you thank you, and yeah, something like this. Sorry.
Thank you, Lena. Thank you. I don't know why you were nervous. That was perfect, and really nice, strong vote of confidence for the work that Alexandru and his colleagues and teams are doing. So thank you. I'm just going to jump in. I know we're almost out of time, but there's one more question I feel I really have to ask. And it's about rehabilitation. So we had a question from Ali about using rehabilitation solutions in remote areas, and whether or not there are really significant problems with broadband speed, and do you have any other solutions for asynchronous, for example, delivery that might be content that doesn't require somebody to be on broadband at the time they're using it. So first I'm going to ask Alexandra, have you experience of using rehabilitation, particularly in remote and rural areas with difficult broadband?
So I'll be very brief. We have no digital solution for rehabilitation. I think for 5 or 10 years, we just wanted to manage the acute part, and we forgot totally about rehabilitation. And it is a huge problem now because we have a lot of patients that are surviving after stroke, but they need rehabilitation. What we introduced and implemented was kinetotherapy in the first 24 hours after stroke. So not just leaving with the patient after 2 weeks to have a proper rehabilitation. And now it is this is implemented, but it's not enough. And usually when the patient goes, they go to different private facilities, or we have some centers of rehabilitation, but it's very hard to be admitted to these facilities, and everything is concentrated in Chisinau. And we have some sanatories, but it's not stroke, not for stroke patients, but for general rehabilitation. And now with COVID, we have different open platforms, and we encourage the relatives to show them on YouTube, on different other platforms that are free, how to do it at home. But properly, we don't have a system in the Republic of Moldova for digitalized solution and rehabilitation. Thank you.
Thank you. I will ask Lorna if you want to come in, as the topic was rehabilitation.
Yeah, so we haven't had too many problems. I think the broadband is getting better over time, and I can't obviously speak for Moldova. I don't know what the broadband situation's like there. We had one problem in a farm on the tip of the South Island in New Zealand, where the chap could see penguins outside his window, and he couldn't get onto the Giraffe platform. What we've done in some parts of Africa where there is limited broadband is our videos are usually about a minute long with voiceovers and things. So we've done little 15-second videos to try and reduce the bandwidth, and obviously looking at alternatives like asynchronous and being able to access offline. So it is, thankfully, is getting better, but we have to be aware that it isn't 100% coverage, I think, in all of our countries at the moment.
Why a mixed approach is probably so important to thinking about it, just being willing to think about delivering in different ways. Okay, Andy, I don't know if you have any final comments. I just wanted to say thank you again. I know we're slightly over time, but thank you very much for everybody joining, and most of all for our speakers for sharing their experience, the good, the bad and the ugly. Andy, any final comments?
This last bit of conversation is exactly why we have these ecosystems, because it's about understanding that we don't only own our problems, it's the same from one country to another. And I think there's so many ways we can connect up some dots here. That's what these sessions are about. There's, I think, ideal opportunity from Ireland, Moldova, Scotland, we've heard today, for people to start to make connections in between countries, and in, as I always say, within them as well, because you can't know everything that's going on around you. And we always have this philosophy at the ECH Alliance, which is about to say, look, let's just get the 80% right, okay? Concentrate on that. Let's not worry about the 100%. That's someone else's problem another day. The 80% here is let's make sure we can see what's going on around us and keep connecting those dots. Thank you to all our speakers today. It's been fascinating to see such similar issues being dealt with such different tools but with the same outcomes. And I'm really pleased. There's lots of ways we can help out. Thank you, Vanessa, for organising this, and colleagues from Scotland too. I'm interested to know, and you can email me, and the email's in the chat function below, what topics you're interested in. We've already got some ideas from colleagues from Moldova. Email me directly, andy@echalliance.com, if you're interested in coming into more of these with colleagues from Scotland and the rest of that global network. Conscious of time, I'm going to wrap it up there unless we've got any other pressing comments.
No, not for me. Thank you. And I think the whole idea around the innovation pipeline is a topic in itself. That's a struggle. Okay, thanks very much, everybody, once again.